to tell you today about some relatively new challenges that are facing healthcare delivery organizations that are arising out of recent efforts to reform the US healthcare system. But first, a little bit of context. In 2016, we spent over $3 trillion on healthcare in the United States. That's more than $10,000 per person. In the 10 years between 2015 and 2025, healthcare spending is expected to grow at a rate of almost 6%, so that by the year 2025, nearly 20% of all spending in the US will be for healthcare. Experts agree that that's an unsustainable rate of spending. Now, to make matters worse, research finds that, study after study finds, that compared to other high-income nations, the United States performs below average across a number of system performance and health outcome metrics. So we spend more for health care, but we get less than our international peers. In the United States today, we're in the midst of what many hope is a paradigm shift, in which we're trying to move from volume to value. That is, from payment arrangements that reward for the volumes of services that reward providers for the volumes of services they provide, with little incentive to attend to the quality of that care or the outcomes of that care, towards value-based payments that reward providers for achieving high-quality, low-cost care and good health outcomes. Now, paying providers for the outcomes that they achieve makes sense on the surface, right? But consider this. Research tells us that there's a long list of factors that actually shape health outcomes. These are the so-called social determinants of health. And of these, healthcare services account for only about 10% of health. That means 90% of your health is attributable to other factors such as your behavior, your genes, the physical environment in which you live, your social support network, and your income and education levels. One thing about these new value-based payment arrangements is that many of them are population-based. That is, they hold providers accountable for the health outcomes and the costs of care for a defined population of patients, usually all members in a particular health insurance plan, regardless of whether or not those individuals ever seek or receive care from the providers. In addition, they put few, if any, restrictions on patients. So patients are free to comply or not comply with their doctor's recommendations, and the doctors are still accountable for the cost, quality, and outcomes of care. Patients are also free to go and seek care from providers outside of the organization, but the organization is still accountable for their health outcomes and the cost and quality of care. All of this means that as we move more and more towards value-based payments, provider organizations will increasingly be accountable for performance metrics that are only partially under their control. So hold that thought for a moment and let me step back. A classic insight from open systems organization theory is that organizations are interdependent with their environments, in the sense that the performance of the organization is not only contingent on what happens inside of the organization, but also on the actions of various other parties in the broader environment, customers, suppliers, and so forth. Now, organizations can engage in a variety of boundary-spanning tactics to try to improve their ability to perform in the face of these interdependencies. They can try to seal off or buffer their internal operations from the fluctuations of supply and demand. They can try to intervene in the environment to make conditions more favorable for them. And healthcare organizations are interdependent with their environment in the same way that big organizations in any industry would be. But what I'm particularly interested in understanding are the new kinds of interdependencies that arise out of these value-based payments and what provider organizations can do about them. So my colleagues and I interviewed leaders of organizations that are at the forefront of many of these value-based payments to learn how they were conceptualizing these challenges and what they were doing about them. And we identified 4 sets of factors that seem to shape interdependency under these value-based payments. First of all, the interdependencies are shaped by the availability of needed services. If patients need a particular service and it's not available, they obviously can't benefit from it. They're going to have worse outcomes. So what organizations can do about that, they can increase the convenience of their existing services. They can have extended office hours. They can allow more same-day appointments. They can staff call centers with nurses who help patients after hours. They can also increase their reach into underserved communities. Now, this might mean setting up new primary care clinics in rural or certain urban communities, but we're also seeing some innovative approaches. A pediatric organization, for example, that was going into the public schools and distributing inhalers to combat high rates of asthma in a particular community. A couple of organizations that were setting up mobile clinics. Large vans equipped with various kinds of medical technology and personnel going in and delivering various preventive screenings, immunizations, and so forth. And of course, they can augment by adding the services that they're missing through mergers and acquisitions, but we're also seeing some interesting contractual arrangements, for example, between hospitals and independent nursing homes or hospitals and independent home health agencies to try to better manage what happens to patients after they've been discharged from hospitals. Second of all, the interdependencies that organizations experience under value-based payments are shaped by the interactions between providers and patients. And so some things that they can do, they can increase the regularity or the frequency of those interactions. The idea here is that if providers are interacting regularly with patients, they have better relationships, they can influence patient choices and behaviors, but they can also understand the factors in the patient's life that may be preventing them from benefiting from the care that they're receiving. There's a variety of communication channels that providers are beginning to use more effectively to remind patients, to engage with patients when they're not in the clinics. They also need to improve the efficiencies of their interactions with patients. And so this might mean using various process improvement approaches like lean to get the waste out of their systems, but it also means addressing gaps in care at the point of care. So that means that when the patient comes into the clinic or the emergency department for one condition, that you simultaneously identify that the patient is also due for various preventive care or screenings or chronic care follow-up, and you either provide that care at that time or you make the appointments to help ensure that the patient gets that care in the near future. The U.S. healthcare system is exceedingly complex. The lives of many patients, particularly lower income patients, are very complex, and we're seeing an increase of patients living with multiple chronic illnesses, which adds complexity. Fragmentations, inefficiencies, and confusions arise out of these many complexities, and they further add to the interdependencies that organizations experience under value-based payments. So there's some things they can do to mitigate the negative impacts of these complexities. They can try to improve coordination among system components. Just getting providers to talk and share information is one piece of that, but it also means managing key transitions of care, such as discharge processes from hospitals, and facilitating in problem solving. So we're seeing an increased use in patient navigators and care coordinators who work with patients to help them troubleshoot problems in their lives, to find food, to find transportation, to find services that will help them actually get the full benefit of the care that they have received. We also see the need to help improve patients' abilities to self-manage. So patient education is very important, helping patients understand their health conditions, understand what contributes to those health conditions, understand their treatment options and their medications and why they're important and how to take them. It sounds like simple things, but it's an area to improve. And in addition, patients that have certain chronic conditions like asthma, diabetes, and so forth, can benefit from having certain tools. So if we equip patients with these tools, they're better able to self-manage. And finally, performance of organizations under these value-based payments appear to be shaped by uncertainties in the environment. Now, on the one hand, this is classic organization theory, but it manifests in some specific ways in this particular context. So first of all, organizations need to improve their awareness of constraints in the environment. And by constraints, I mean the relatively stable features of the environment. In this context, that pertains primarily to features of the population for which the organization is accountable. What's the distribution of health and various illnesses within that population? How are resources, healthcare resources, being utilized appropriately or inappropriately within that population? It's important that organizations understand this so they know how to direct their use of resources. This takes actually pretty sophisticated information architectures to be able to monitor the populations like this. Interoperable electronic health records that span the care continuum, disease registries that track patients who have particular illnesses to see if they're getting the appropriate care at various stages of those illnesses, and sophisticated data analytic capabilities to mine and make sense of that data. Those are skills that most healthcare organizations don't necessarily already have in-house. Organizations also need to improve their awareness of contingencies. These are the more rapidly changeable features of the environment, and in this context, that pertains primarily to certain subsets of patients who, by virtue of the complexity of their life situation or because of their multiple illnesses, are at high risk of deteriorating rapidly. We know that patients who are at high risk of deteriorating rapidly end up needing more services, more expensive services, and they usually have worse outcomes. So identifying where these sort of vulnerabilities are and intervening early is important. Again, care coordinators and navigators are proving to be one useful resource for that. There may indeed be others. So in short, we've identified 4 sets of factors that seem to shape the interdependencies that organizations experience under these new value-based payments, and a variety of tactics, certainly by no means the only tactics, but a variety of tactics that they could use, but more research is needed to test the actual impact of these various tactics. Thank you.